Thank you. Good afternoon, everybody. How was your lunch? I had the veggie sandwich. Anybody else? So good. I ate 2. Delicious. I didn't eat the fries or the brownie, though. So if someone wants to dumpster dive and get some extra dessert, feel free. We're going to use a technology called Poll Everywhere. Some of you have already figured it out. And it's pretty straightforward if you know how to text, which is a big assumption sometimes. So in the to part of your text, we're going to use the same number, 22333, and then in the body of your message, you'll be using different response codes for each of your answers, okay? So if you don't know how to text and you're sitting next to somebody that does, just nudge them. If you work for a health department or agency that you have a business phone and you can't text, I am not responsible for any charges that are incurred, okay? So we're just going to get a sample because I know some of you feel very constrained, all right? But it's great to be here in Tennessee, and I just want you to know that we are all looking to Tennessee for a lot of different reasons. You have an incredible cadre of public health leaders here. I've been in public health for 15 years, and I have always been impressed by both your local and your state public health leadership. And so it's a really nice opportunity for me to come back and thank you all for the work that you've done, and to share with you some of what we're doing on your behalf in Washington. My organization is the Association of Maternal and Child Health Programs. I'm not an MCH professional. I work for MCH professionals, folks like Michael, other folks here in the room that work in the state health department, and partners at the local level are all of our members. And on your behalf, we advocate for funding federally for maternal and child health programs. We are a resource for state health departments on maternal and child health issues. And we are a partner with many other organizations, both in D.C. and around the country, folks like Michael Liu, who presented earlier, folks like Chad, who's here from City Match with some of his folks, Sherry Pies, who's here from the university setting. We do a lot of partnership work. And you've got a great lineup here, and I don't want to steal any of their thunder. What I'm going to do this morning instead, or this afternoon instead, is synthesize some of those things that we've heard about this morning, and hopefully you've been thinking about as well. And so to gauge that, and thank you. So let's talk about this real briefly. What are the none of the aboves? Give me some idea of what I missed here. Disney World. What else? What's that? Sedona. Very new age, okay. What? Where? South Africa. Who said Cleveland? Oh, New Zealand. Gotcha. Okay. Well, we're going to move ahead, and I hope you all have some fun. This is a serious subject. There's no reason that we have to be serious all the time, though. And I want to show you some slides, and I'll do that in a minute. Some people complain about motion sickness when I use this technology, so feel free to close your eyes. But I want to do a little bit of a pretest. So I went to the bookstore behind the room over there, and I bought a blue book. Do you remember these? This is like the fear of death when you see one of these. So I bought one just because, I don't know, masochistic that way. But I want to do a pretest, and I want you to text your honest response to this question. I feel confident that I can describe how my work in Tennessee fits into national efforts to improve birth outcomes. I feel confident that I can describe how my work in Tennessee fits into national efforts to improve birth outcomes. We're just going to do a baseline here. No one's going to get graded, and I don't know who answered it. But let's get a sense of the group here. And my colleague, Pia, who we are so pleased to have with us in Washington, and she used to be here in Nashville. Pia, want to raise your hand? She's here from AMCHP, and she's going to keep these results so we can do a pre- and post-test. This is great. We're getting a good sense of the group here. I'm going to wait till we get about 30 or 40 responses, because it seems like that's the sum of all of you that know how to send a text, apparently. Just kidding. There's no tomatoes in that lunchbox, which is good. All right, this is good. So there's some real positive results here, and so we're working with a group that feels confident. We shared earlier this morning, we heard from Michael Liu, Dr. Gunn and Kentucky about some of their efforts, and I think you can see some connections. And that's the point of what we're trying to do today, is to connect, what I'm trying to do today, is to connect your work to the bigger enterprise of maternal and child health, work that we have been doing for some time in maternal and child health programs in state and local health departments, but is now getting a lot of traction from some really important places. So this is great. So we may not see, Pia, too much movement here, but do you have these so I can? Okay. Thank you. A few more, a few more. See if we can move some of those around. One last pretest, and then we'll get into the meat of it. You with me on this? It's working for you? All right. I feel confident I can lead and implement efforts to improve birth outcomes in Tennessee. I feel confident that I can lead and implement efforts to improve birth outcomes in Tennessee. Well, we got those outliers first at the draw here. That's great. It's only 2 of y'all, though. There we go. That's what I like to see. Some movement. It's kind of like that game with the, at the fair with the water pistol going into the horses running across the track. Let's see who wins. We'll wait for a couple more. Great. We have a very confident group here. So what this helps me do is tailor some of my remarks to those of you who I can sense are feeling really good about the work here, connecting it nationally, and maybe I can spend some more time on detail that I might not otherwise share with you. And I'm also thrilled that 70 of you are now using your phones. That gives us a much better sample, right, Lauren, our epidemiologist friend that I know. All right. And hopefully everybody had a little bit of fun with that. That's a good technology. It's free. I'm happy to share that with you. So the title of my talk on your printed agenda is changed. I always like to mix things up a little bit. And what I want to do today is talk about Tennessee, but I want to do it in the context of what's going on nationally. And I want to pose to you that infant mortality isn't really the issue. It's our priorities. Where are we putting our priorities, both here in the state and nationally? In the richest country in the world, it's hard to believe that we rank at the bottom of nations compared to us on infant mortality, that our rates are, depending on how you count it, in the low 30s, potentially 41st. In terms of our rates, as Dr. John shared this morning, 2.3 in Bermuda. Our average in the U.S. is somewhere around 6. And that's for all of us. That's not for our brothers and sisters who don't share the same complexion of the majority. And so I think what we need to talk about when we talk about infant mortality is our priorities as a country, as a state, and as a community, and refocus our priority on what every American believes to be the most important thing to them in their lives, their kids. If I walked out on the main street on Broadway, maybe not Broadway, somewhere else, and I asked, what's the most important thing to you in your life? 95% of people would say their kids. And so as we look at infant mortality and we look at the science and we look at the technical issues and we look at the research and we share our numbers, just be reminded that what we're looking at is a physical manifestation of priorities that we have set in our nation, in our states, in our communities. And that's a challenge to you all here as maternal and child health leaders. And it's a challenge for us as advocates in DC, and it's a challenge for us to share. Because for us to really make a difference, it's not going to be how many nurse-family partnership programs we have in our state, how many MCH epidemiologists we employ, how many NICUs we set up. For us to make a difference in our state is going to be truly to change the conversation about priorities in our communities, in our states, so that moms and kids, fathers and families become the reason that we are here. And so I know I'm preaching to the choir for that, and I feel like I'm at church because nobody's sitting up front. So we talked about these, we talked about your confidence, and that's my political side. Now we're going to get into some more fun stuff, maybe. When you think about infant mortality, sometimes it feels like you're trying to sweep up the beach. I mean, you could just spend so much time trying to sweep up the beach, and there would always be sand, right? It feels like a task that's beyond solving, and even if we just scoop up some more sand, we'll feel better. So we got to put our eyes on the prize with this one, which is where are we trying to go? Are we going to be able to sweep up the beach? And this is part of the conversation for you. What's realistic in terms of goal setting and the rates for you here in Tennessee? And that's going to vary based on who you're working with, your community, and what's important in your political setting and in your community. It can also feel like you're trying to just wash windows. There's a building that looks a lot like this downtown. I mean, I talk to folks working in maternal and child health, and they just feel like they're constantly get one window clean, the next one gets dirty, the one behind you there's just an endless amount of work to do. And so part of you all coming together today is to share that frustration, but also to share in the resilience that we all have to do this work and remember why we're doing it in the first place. Okay? So what I want to challenge you to do today is not just learn, but also think about how can we become resilient MCH leaders in the sense that this is a task that requires so much lift and so much work. We need to approach it in a fresh way sometimes, and we need to learn from each other moving forward. We don't want to be like the Greek myth of Sisyphus, who's constantly trying to roll the boulder up the hill, and it's constantly rolling back on him, cursed into eternity to try and roll this boulder up the hill. We will change. You have seen change in the data, even presented this morning. We will get better. We will solve this problem, but it's going to take some time. But when you feel like your efforts aren't connected, you feel like you don't know what else you can do, you feel like everything you've tried isn't working, that's the time to share like this and really begin to talk to colleagues about what they're doing, because in that sharing you will learn new methods, new techniques, and new strategies. And that's what's so fun about what's going on nationally. And we're seeing success. This is just an example. In the District of Columbia, they have seriously addressed the issue of infant mortality in a multi-pronged approach in one of the most challenged jurisdictions in the country, and have made a significant dent in their infant mortality rate, in a place where all hope had been forsaken for many, many years. They have made change. And that's exciting for us. That shows us that this is possible. It inspires us to move forward. I do want to note again, and these are old data up to 2006, that when we're talking about infant mortality, we're really talking about disparity. And behind the overall rate is a tragically, a very sad picture of unequal opportunity in our country that plays itself out in the lives of newborns. And you can see in any place you go that while we've made a tremendous difference in the infant mortality rate, look at this change even in just 10, 11 years, and the trends are still going down, that there is a persistent gap between African American and non-African American infant mortality rates in this country, and between white and other racial groups in this country. And again, I will posit to you that that's the result of a lot of things that we can't fix necessarily in maternal and child health, but we can be part of fixing moving forward. Things like housing, economic opportunity, social determinants of health. Places where we haven't played before well are now becoming ripe for maternal and child health perspective. Housing, education, economic development. That's what's going to move that gap closer and hopefully one day eliminate it. That's what we're all working towards. You all know this, don't you? This isn't a surprise. This is why we're doing this work. So, 41st in the nation. This was an article, anybody read USA Today? It's got this thing on the editorial page, pros and cons, so it's kind of weird to have a pro infant mortality, con infant mortality. So what they did was talk about how rates are calculated. And so, they had some scientists say we're 41st in the world, and then some scientists at the bottom saying, no, we're not, we calculated incorrectly, the numbers aren't comparable, we wouldn't be 41st. Guess what, folks? It doesn't matter, we're not first, okay? It doesn't, if we're 39th or 41st, it doesn't matter. If we're 22nd and we're not first, it doesn't matter. If this was the Olympics and our Olympians came home with no medals, really? We want the gold, okay? We win the gold when it comes to healthcare spending, and we lose when it comes to health outcomes, okay? So this is an important piece for us in the next issue of USA Today. I did an editorial on that. They published it. It was really nice. But basically said, it doesn't matter what the numbers are. If you think we're 32nd or 41st, we're still 32nd, folks, among peer developed countries in the world, not just Bermuda. And if you look at the history of our country and the diversity of our country, you'll see it's hard. And I was overhearing a group earlier talking about the heterogeneity, the diversity of our country. And it is true that in the South and the Southwest, we have the highest infant mortality rates in the country. They're also the most diverse places in the country. And so infant mortality solutions in Tennessee aren't going to look like infant mortality solutions in Maine, where 98% of the population is European American. They're not going to look like the infant mortality solutions in California, where 18% of our births happen. They're going to look like the infant mortality solutions for Tennessee, and that's why you're working as a group. What's going to work here, you know, because you're here. You're part of that community. And so what I want to share with you today is just some learning that we have from other efforts, but not to ask you to implement all this, because it's not going to work. You know what works here, and that's part of your sharing today. So we set a national goal through our Healthy People 2020 efforts of reaching 6.0 infant deaths per 1,000 live births. And again, that masks this inequality, this disparity. We are close to reaching that goal. I think in 2014, we're going to hit 6.4. We may even hit 6. And some states have already gone below this. Okay? So not very aspirational, but certainly here, there's room for improvement. And anyone could argue that 0.001% is one baby too many. So we all have work to do. The work that's going on nationally it's insane how much activity there is, to be honest with you. It's really almost impossible to track. And I'm going to show you some of those efforts, okay? But we heard from Kentucky today. Our friends from Kentucky still here. They are doing amazing work in Kentucky, as you mentioned, just close by. Their Healthy Babies Worth the Wait is a wonderful program. And if you haven't seen the video that I'm about to show you, you will this fall, because it's going to be rolled out nationally as part of a public awareness campaign for prematurity prevention, the big priority for March of Dimes. You want to see a movie? Or you want me? Don't you love that? I love that. I don't even know why I'm clapping. They're not even here. I love that. And what we've done with the Association of State and Territorial Health Officials, ASTO, and March of Dimes is to begin to make this available to states this fall so that you can tailor it for your message and put your logo on there and put information about your resources on there. So it's a wonderful resource. I think that's great. But that's one part of the infant mortality problem, prematurity, elective delivery before 39 weeks. And that's a core piece of what March of Dimes is doing, a big national initiative. The Association of State and Territorial Health Officials, Dr. Dreisner mentioned he was in Austin last week. This morning I was there too. It's the convening of all the nation's John Dreisners, of which there are, every state has one, not like John, but certainly other folks. And so our colleagues were there, and the folks that our members work for, and 49 of them, plus the District of Columbia and Puerto Rico, accepted the president's challenge to reduce prematurity by 8% in their states by 2014. And it's a tremendous initiative. That has great leadership and good partnership going on in every state. The one state that's a holdout, it's not because they don't think infant mortality is a priority, it's just that they don't think they can get to 8% realistically. And so they want to have a little bit of a different goal for themselves. And if you can get 49 states to agree on something, that's pretty amazing in this country, honestly. HRSA, Michael Liu was here this morning representing the Maternal and Child Health Bureau. He talked about the COIN project, which is the collaborative innovation network that all of the region here for, but also SIX is a part of, and expanding that nationwide. You're familiar with this. You have leadership here that's participating. He mentioned Dr. Taylor is leading one of our groups. This is an incredible opportunity to think about infant mortality in a little bit different way with some focused attention. And it was not the result of people in Washington saying, let's do this. It was a result of states, state MCH leaders saying, we've got to do something about infant mortality in our regions. And that led to the creation of, ultimately, this COIN project. And I want to talk about the pillars of COIN real quickly, because I think they will mimic what you're doing here in Tennessee. Obviously, you're part of the COIN. But for the national rollout of this, again, it focuses in 5 main areas. And you're working in all of these. The first is to reduce elective delivery before 39 weeks. And I want to show you another video that Oklahoma has developed as a PSA that they've already begun to distribute in their state. Like that one? Different take. It's not as dramatic necessarily as this pre-post baby delivered cuteness, but a good one nonetheless. Another state effort to begin to address this issue of 39 weeks. It's actually 40 weeks, isn't it, that we really want to see? I'm just saying. Okay. So another part of the COIN is access to preconception and interconception care. And that's a huge piece, especially in this region where you have a history of clinical service delivery through your public health departments. In other states, that not necessarily as strong. But how do we ensure access not just when a woman is pregnant, but throughout her life course, should she decide to get pregnant or not. And how do we keep women in healthcare when they're not pregnant, the interconception period? How do we impact women's health overall? So you'll see a real focus on women's health in a lot of these efforts. Women's health across the life course, not just during pregnancy. And it was mentioned earlier that a lot of the focus, the old school infant mortality reduction was just increased prenatal access to prenatal care. Now we're really beginning to see that 9 months of prenatal care is not going to reverse a lifetime of poor health and expect a good outcome for that woman and her family. So a lot of attention on preconception, interconception care, and we can talk more about that as we move forward. Smoking cessation, it was mentioned again this morning that even just a 3% reduction in this state would lead to huge savings, both in lives, but also in dollars. It's a strategy that works, and one that we have an incredible opportunity to expand through the Affordable Care Act, which makes smoking cessation programs a mandatory piece of Medicaid moving forward. Safe sleep. It's hard to believe that one of our biggest successes was in public health was the Back to Sleep campaign. We sort of forgot about that from the late 80s and moving forward. But core to infant mortality prevention is this issue of safe sleep, and how you approach that is going to be very different in Tennessee based on the cultural norms that folks have in this state versus another state that might have a whole other set of cultural norms of populations that believe sleeping with your baby is the right thing to do. How do you do that well in a place? You know what that's like working in communities, and each of us will have a different solution to that particular strategy. So the fifth part of the COIN program of their strategy sessions is promoting perinatal regionalization. It's interesting to look at states and where the resource is for preemie babies and how that's distributed across the state. Some states have taken this on as a major issue. Some states haven't yet. And we want women to deliver where the best care is for that woman and her family. And looking at your state and where its distribution of facilities can be a really important learning, but also a big piece of solving infant mortality so that those folks can reach appropriate care when they need it. And this is a tough one because you have to work with the payers, you have to work with the healthcare facilities, and you have to really have some tough conversations about who needs what kind of resource. So these 5 strategies are a huge piece of COIN, and I know all of you are working on them, but that sort of forms the backbone of the HRSA effort, of which you are a big part here in Tennessee. So Dr. Liu read Kathleen Sebelius's remarks on the National Infant Mortality Strategy, and the National Infant Mortality Strategy is still being cooked. It's not a finished product yet. And part of what's really exciting about the National Infant Mortality Strategy, as Dr. Liu mentioned, is this is the first time the nation has committed to a national strategy. But what he failed to mention, which I think is an important piece for us in states, is that there are state strategies that have been around for 20, 30 years on infant mortality. And what we look to the states for is that innovation and leadership, and eventually the folks in Washington catch up. And what we're seeing with the National Infant Mortality Strategy is Washington finally catching up and saying, well, let's take what the states have learned and make that a national strategy. And you can be assured with Dr. Liu's leadership and the folks that are on the Secretary's Advisory Committee that that's going to be a plan that includes all of the things we care the most about. And I can assure you it's going to be a plan that is going to work for states and for local public health systems, which has not necessarily been true in the past. Finally, the other big national strategies that I'll talk about are from the Centers for Medicaid and Medicare Services, the Strong Start program, which is an experiment in ways to improve birth outcomes through changing the prenatal care experience through Medicaid reimbursements, is really exciting. And as was mentioned by the folks in Kentucky, centering model is a big one here. There's a couple others, 2 others that are supported, to really look at, okay, if we do this and we do it well and we do it right with some resources, does it work? And if it works, can we take that learning and spread it? So there's a lot going on in the Medicaid community. Why is there a lot going on in the Medicaid community when it comes to infant mortality and prematurity prevention? Huh? I can't hear you. You're so far away, I can't hear a word you're saying. It's a cost issue, right? It's a money issue, right? So if you can keep a family to have a normal delivery, a typical delivery, you're talking about a $6,000 bill. I don't know what it is here. Okay, anyone from 10 Care here? What's a normal delivery, typical delivery cost? 4,000. Okay, thank you. What's a NICU baby cost per day or over the course of their stay in a NICU? 50, 60,000? Is that about right? Huh? Yeah, I can't see. Okay, thank you. So, we're talking about not only the right thing to do, but in this time of budget constraint, why do you think 49 states signed on to a prematurity prevention pledge? It was the right thing to do, but there's only 49 states. There's 49 states that have a surplus. There's only one state. There's 49 states that have a deficit. There's only one state that has a surplus. Okay? And so governors, health directors, payers are now paying some pretty serious attention to the savings that they can get in full-term typical births. Okay? It's the right thing to do, but it's also, there's an economic driver there. And you can see some incredible data that show that. In Texas, they invested $4 million in a Healthy Texas Babies program, and they saved millions in their Medicaid in a short period of time by putting a hard stop to non-medically indicated delivery before 39 weeks. It was a political solution. That wasn't a technical solution. It was a priorities issue. It wasn't a research issue. Okay? Really incredible work that they're doing there. Whether you can do that here, something to talk about this afternoon. Okay, so I just shared 5 or 6 national initiatives. Let's see. Have you heard about the HRSA coin, the Strong Start program, the Ask the President's Challenge, the Healthy Babies Worth the Wait? Have you heard about all of these? Let's see how many of you have heard about all of them. If you've heard about all of them, there's 5. Let's see what you got. If you only heard about one of them, let's see what you got. These are the big national initiatives that are going on right now on infant mortality. So I mentioned 5. This is the list. I'm not expecting you to read it. This is a list, an inventory of efforts going on nationally on infant mortality, prematurity prevention, that I got at a meeting I was at last week. And I figured I'd scan it and show it to you. Not to show you what the individual things are, but that there's over 50 programs, initiatives, activities going on nationally right now to address the issue of infant mortality. That's why we're getting so much traction on this. But that's why it feels so difficult to try and manage all of these. And a lot of them have a small piece of the pie. A lot of them are pretty esoteric, changing data systems, changing all kinds of minor things. But some of them are taking on some of the bigger health equity challenges, the social determinants issue. So it's really a cross-cut. And there is a lot of activity. If just trying to sort this out is really, really difficult. But they all share some core features. And I want to just give you a brief flavor of some of these. In addition to what the coin is focusing on, a lot of these national efforts share some characteristics, and they share a lot of what you are doing here. There's a huge effort now to improve quality of obstetrics, quality of care, anything that has to do with where can we get better outcomes through continuous quality improvement is really, really hot right now. And it's wonderful to see. Now, those are going to have an effect on outcomes, but quality focuses on the clinical, right, for the most part. And we know a lot of what determines birth outcomes happens outside the doctor's office, outside the clinical encounter. So we also have to begin to think about what does quality mean in public health? What does quality mean in the state health department? What does quality mean when I'm working in the community? And what can I learn from our folks that focus on quality in the healthcare setting? Health promotion is big. Health Text for Baby is huge. It's a great way to think about using technology in our public health departments. I was just down in Texas. I'm going to share a link with you in a minute, but they've created basically a Text for Baby for dads, an app that they're going to begin to use in Texas, and they said they'd share it as soon as that's finalized, and we could all begin to use that. But really focusing on what happens outside of the clinical encounter to keep women healthy, should they choose to become pregnant. And I think that this is where we have the biggest bang for buck in public health, in terms of what are the programs that we support, what are the population-based campaigns that we can run, what are the places we can put our resources to truly impact the population's health around this issue. When you look at the federal, and this is just federal investments in programs for women and children, we have a tremendous opportunity to integrate and consolidate. When I show this slide to policymakers, I get scared, because they think, well, we don't need all of these, do we? Can't we just have 1 or 2 of these? And I have to explain that each of these was developed to meet a need, to meet a priority. But yeah, managing this spaghetti bowl of programs to improve the health of women and children, to improve the lives of families, is a lot of work. You know what that's like if you run more than one program or manage more than one funding stream. And for that reason, how we integrate services is incredibly important, not just for efficiency's sake and quality's sake, but because it makes sense for the families that we work with. So if you have a home visitor going into a program, followed by a social worker going in with the family, followed by a case manager going in with the family, followed by an 800 number they have to call for the children with special health care needs, followed by whatever follow-up they need with the specialist, followed by someone to help with economic issues, and then a home visitor coming in to work with the child, you can see that that is a lot of resource. And probably there's a more efficient way to do it, and we'll see better outcomes in the process. National initiatives are focusing on data and research and surveillance. How can we get real-time information about what's going on in our state? One of the things that Dr. Lakey said last week in Texas was, I don't want to be a data historian as health commissioner of my state. I want to use data to make decisions. And so he's begun to challenge his agency to give him real-time data on what's going on in the state and use those data for decision-making versus waiting the 3 years that it normally takes to get cleaned up vital statistics records and saying, okay, we got a problem here. And so think about how you use data in ways that you might be able to link data, share data, get data more quickly to inform decision-making. This is a picture almost 100 years old of an epidemiological study of infant mortality and fathers' earnings. We're still asking that question using slides that are a little more complex, but not much. And it just shows this has always been a struggle for us in maternal and child health. But here's the slide I really want you to think about. This is the break room of a health department. You know where I'm going with this? Every one of these coffee pots belonged to a particular program in that health department. There was the MCH coffee pot, the TB coffee pot, the HIV coffee pot. You know what I'm talking about? Maybe you don't have it here because it's not your health department, okay? Every one of those programs had its own coffee pot. When I walked in that break room and I took this picture, I knew what the issue was. It was collaboration. It was integration, right? It might have been money. Okay, I'll give you that because I couldn't buy coffee. But how does this really reflect current maternal and child health practice? How does this reflect what we do in our own agencies that we can fix? Okay, are we sharing the coffee? Are we learning from each other? Are we able to build systems that cross-cut the different silos in which we work and bring together the different funding streams that pay us and allow us to do our work? Or are we going to perpetuate this? I would posit to you that the outcomes that we get today are the result of the systems that we have today. And for us to actually create change, we're going to have to change the systems in which we work and do work differently. And that's, again, the power of what you're doing here and the sharing of what's going on nationally. Folks are beginning to change the way they do things. And as I mentioned earlier, the focus on women's health is just a huge, huge component of what's going on in national efforts. So, of those 7 things I just described, do you want me to go through them again? Of those 7 things I just described, to focus on women's health, public-private collaboration, cross-agency integration, research and data, surveillance, integration of services for women and children, health promotion, and a focus on quality. Of those, how many are you using in your work? If you can remember all those, how many of those are you using in your work? Let's get a sense of that. I want to see how you guys are doing here with all these different threads. How many of those different techniques? Focus on quality, service integration, data, surveillance, interconception, women's health issues. Good. Good. A lot of comprehensive work going on here. And it might not be that you have to do all of those. It might be instead that you have to assure that all of that's happening in your district, in your organization. Some are unsure, but good. Many of you are employing all these strategies, features of what's already going on nationally. And again, that's why we look to you as leaders. That's a good sense, a good sample. Lauren, you happy with that sample, 42? All right, she's good, I'm good. Our epidemiologist nodding, always a good sign. We're going to keep going fast through these. In your packet, and I won't go through all these in particular, in your packet is a compendium. And what we did with this compendium is query every state and ask, do you have an infant mortality reduction plan? What are you doing around infant mortality strategy? Can you tell us what some of your programs are? Can you tell us what's working in your community? We profiled several states in the back. And so if you're thinking about, all right, how do I do all of this? Here's your menu. Here's your menu of options. This is how other states have addressed the infant mortality issue. I also include a little bit about Title V and what your state health department does. Here is history, but this big one, our compendium here, is a great resource for what you do to address infant mortality at the state level. And again, we have plenty of these. We're happy to share them. And if you'd like more, it's also available online as a PDF to send out to partners or students that want to do papers with these, whatever. It's a great resource. But we came up with 7 core recommendations. And I'm not going to repeat them all because they're all A, here, and you can read them. But B, they echo a lot of what's already been said. But I want to just focus on one. So yes, it talks about health promotion. Yes, it talks about ensuring care. This is the website for the Texas program around preconception health. Someday is now. It's not ready yet. I was just there when we were down in Austin and visited with them. It's going to be ready around the 1st of October, next couple weeks. Great resource here for preconception health if you're thinking about that here. But the piece that I really want to focus on is one of the strategies that we leave out because, again, it feels like it's just going to be too much work or it feels like there's nothing we can do. Okay? But as Michael Luce said, e pluribus unum, we're all in this together. And a major strategy that should be part of infant mortality reduction plans is to promote social equity and to address the root causes of health disparities. If we don't do that, we're not going to see the kind of change that we expect. And I know, again, you all have spent some time thinking about that here in Tennessee. Probably a lot more to do in that area. Another part of national initiatives that's going to look at some change, I love this slide. Do you love this slide? It's a commercial for Evian water. I saw it on the van of a truck. And I got a picture of it online. And it's not about Evian that I think makes it good for this talk. It's about this attention to the life course. It's about we carry with us all that happened to us before, psychologically, but also physically. And this notion that, again, you can reverse the ill effects of poor health in the 9 months of prenatal care and expect to have a positive outcome when you're not looking at all the other factors that have led necessarily maybe to stress, that have led to other chronic disease outcomes. We carry with us as individuals all that's happened to us before, and that's going to impact our health, but it's going to impact the health of our children. We're learning now with new science that some of that stress will impact pregnancy outcomes. Some of those chronic conditions will impact birth outcomes. And so if you take a life course model, and many of us begun to really think about this, it changes the paradigm in how we approach infant mortality. It moves us from reproductive age all the way to birth. It's like a cyclical, really developmental, and for us, really exciting way of looking at infant mortality and looking at health overall. And so you'll see a lot more about the life course coming out from us and our partners. I believe that there's some presentations tomorrow on this as well, to really think about what this means for our work in maternal and child health, especially when we're really focused on the provision of services to women of reproductive age. We have to move much further back in the lifespan and actually start thinking generationally in what we do in maternal and child health. Does this help illustrate that? I think this is fantastic. I think it's fantastic. And I don't own stock in Evian. All right, so key features. We'll wrap it up. Key features. All national initiatives are really, if you look at all these things I talked about, the list that I tried to show you, and some of those videos help illustrate, all of them are addressing women's health. I call this putting the W in MCH. And it really is an important major pillar of all strategies. Does that make sense? Absolutely. Why haven't we done it before? We've really, the political agenda hasn't been to say that, but that is an important piece. Assure access to quality care. Address all levels of health impact. I didn't share that with you, but don't just focus on the clinical side, focus on the socioeconomic, focus on the population-based health approaches, focus on the things we can do in communities, not just in terms of clinical care. Integrate and cross-cut silos and turf, and build capacity for data and research. Those are really the 5 key features of national efforts. And I'm proud to see that you all are incorporating most of this, if not all of it, in your work. But what we also have to do is begin to really think about ourselves as MCH leaders. An MCH leader inspires and brings people together to improve the lives of the MCH population. You set a vision and you move forward to implement that vision with partners, with colleagues, with the work you're doing. You inspire, you bring people together, and you set a vision. That's what you're doing today. That's what you should be doing every day. We need you as MCH leaders moving forward. We are in a time of tremendous challenge, both politically, economically, but also there's just so much to do that we have to begin to reset our priorities and really look at what's that vision for infant mortality in your communities, here in your state, and how does that dovetail with what we're trying to do nationally. A lot of that work's going to come by putting pieces together. And again, that's the beautiful part of what you've done today. Put the pieces together, integrate, cross-cut, getting a very rich perspective today from all these presentations. And to address the challenges that we see coming down the pike. Okay? To know that for us to really address the issue of infant mortality isn't going to be to put more clinical capacity, although that might be a strategy, it's not the solution, or to do more home visiting, or to do X, Y, and Z, to improve breastfeeding rates. It's all of those things. And how do we make that happen? So let's see how we did. Let's take our post-test. You ready? I didn't get any amens on that, but I'm assuming you are. So let's do our post-test here, and Pia is going to help us share. Let's see how this changed it all. I hope it didn't go down. That would be embarrassing. I feel confident that I can describe how my work in Tennessee fits into national efforts to improve birth outcomes. We just shared 45 minutes on national efforts to improve birth outcomes. I'll call that success, but we only had one. Lauren, what do you think about that? You need a little bit more. Okay. We'll get some more. I don't know. I made it worse for one person. Do you remember how many results we had when we first did it, Pia? It's about this, right? More people are voting, so our samples aren't the same. But what does that look like? Any improvement? Huh? We went from 33 to 64%, strongly agree, and then, what? That was the Sedona vacation. Gotcha. What about agrees? 38 to 32. So we had some people moving up, right? From agree to strongly agree, from disagree to neutral. And the two of you on disagree and strongly disagree, please stay after class. We'll have a little tutorial here. And let's talk about your confidence around leadership. That's great, by the way. Thank you. Let's talk about leadership. This is our last test, and then we'll move on. I feel confident that I can describe how my work in Tennessee fits into national efforts to improve birth outcomes. Let's see how that looks. That one person. Thank you. Oh my. What do they call this? A modal, bimodal distribution? Unimodal distribution? I call it good. What? It was? All right, we're going to rely on our data historian here, Pia, to share. Where were we when we started? 32 to 76%. Well, Dr. Warren, I think my work here is done. Thank you all for your time. I really appreciate it. Let us know how you're doing and how we can help.